Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Good morning, everyone. Oh my gosh, I love tuning in each week and connecting with all of you. It literally allows me to jump out of bed, head over to the microphone, and say hello to all of you. So good morning. I'm so happy we're able to connect today on Breast Cancer Conversations. I'm your host, Laura Carfig, and if you're joining us for the first time, welcome. Be sure to subscribe to our podcast and receive notifications each week when we come out with a new episode. You can find our podcast on Apple Podcast, Google Play, Spotify, Stitcher, and SoundCloud. We also started something new. If you haven't heard of Patreon, go check it out. We have our very own Patreon account, and it is a great way to support the work that we do so we can continue to offer this content. And for all of you who tune in each week, I am so thrilled that we are able to connect again today. This is a throwback to September when we were at the Living Beyond Breast Cancer Conference in Philadelphia, Pennsylvania. And we got to run into one of my favorite doctors, Dr. Monique Gary, who is a breast oncologist surgeon. And her and I have been going back and forth for months. We met up in Boston. We had dinner together. And we've been trying to get her on the podcast. And after her presentation, she came over to our exhibit booth. We hugged, embraced, and was like, oh my gosh, you're here. We are doing this right here, right now, in real time. So what transpires is a lovely, high-energy conversation about breast cancer, about how we can take care of ourselves, how we deserve to take care of ourselves, how we can explore intimacy and relationships, and that having these relationships is our right. So let's dive right in. Welcome to the conversation.
Things are busy, and it's good. It's busy for all the right reasons. You know, I know you can relate.
I know. So I think the last time we saw you, we were up in Boston.
Yes.
And you were there for that
The
conference.
Fellows, the College of Surgeons.
Yes.
Yeah.
How is that going?
Everything's fine with that. You know, I'm inducted into the College of Surgeons as a fellow.
Congratulations.
So, yes, thanks. That's like the last sort of final award or achievement that a surgeon can get.
Really?
Yes, the highest one. Yep.
Oh, excellent.
More letters behind the name, you know, that sort of thing.
That's what we do, right?
Yeah,
Like in academia, you're like, just give me more.
More letters. Yeah. Yeah, you want to go back for your MBA? Wait.
I know, exactly.
But it's there, you know.
Oh, awesome.
Oh my goodness.
Well,
How about
thank you so much for taking the time for this podcast as well. So I think since we last spoke, so much has happened with survivingbreastcancer.org. We have been growing and growing and growing. Good. And just like any nonprofit, my friends keep warning me about this, where there's mission creep and everyone has an idea and they want to take you in different directions. So there's been a lot of kind of accordion effects of growing and then shrinking and coming back down to what we're trying to really do.
You got to stop and do your strategic plan and redo your plan and then work your plan and then reconnoiter.
Exactly.
Yep, it's true.
But we are pretty committed right now to the pillars of education, resources, and community. Okay. And we're creating programs now mainly online and virtual so that we can impact more people quicker. I love it.
Yes.
But of course we want to do in person. It's really nice to put faces and names together. And when financial resources allow us to do that, we will.
Right. But the global community is getting so much larger, and it's really important to have that presence though, because we can be everywhere and we can be connected, and there can still be this connection with someone who's who's in the UK, someone who's in Australia, someone who's in Alaska, a breast cancer survivor who needs support and needs a circle.
Right. And this year alone, we've had some interns volunteering from us from China and India.
Oh my God,
and
that's great.
And they've been giving us perspective of what it's like to have cancer in some of these other countries.
Yes.
What is the access to the resources? What is the standard of care there? And we've had some really great deep conversations about, okay, yes, I have breast cancer, I go through chemotherapy, surgery, radiation, but this is where the incongruencies are. Yes. And so it's been really eye-opening, actually, to be able to be inclusive and also learn from how we're treating breast cancer as a whole globally.
Yep.
So we've started a podcast.
Okay, fantastic.
Because there's so much to talk about, right?
It's true.
I call my podcast Breast Cancer Conversations.
Okay.
Where we talk about all things breast cancer. And that can be anywhere from hearing survivor stories, hearing from women and men all through different stages, whether they're 0 or stage 4, whether they're ER positive or triple negative or globular. There's so many options, which is why we just kind of come together on a podcast weekly and share conversation about breast cancer. then the other thing that I really love to do about my job is kind of listening to our community.
Okay.
They're asking questions, and I'm like, I'm going to go out and I'm going to find the answers.
Got it. Yeah.
So we have been so fortunate to be able to partner with some other doctors in the medical field.
Yep.
And kind of debunk some of the myths, right?
I was just going to say, do you have questions today? Are there? Yeah, that's great.
Absolutely. So, we talked to a couple of radiologists, and I was like, really, tell me what happens when we get the call back. Like, what does that mean? And there's a lot of conversation, too, about the types of mammography we should be advocating for.
Good.
So, should I be advocating for 3D mammography?
Yes.
Should I be looking for contrast or molecular breast imaging? I mean, there's so many options that it's overwhelming. So let's go to the experts, talk to them, and have them share with our community.
That's right. Oh, I love that.
That is what we're up to, and I'm so thrilled to have you, Dr. Monique Gary, on the show.
I am so thrilled to be here. Thank you very much.
Wonderful. Well, I will just turn things over to you to let you do your own introduction and let our listeners know a little bit more about your background. And obviously, we kind of connected online and then in person. But it's just a pleasure to have you here.
Well, thank you so much for having me. My name is Dr. Monique Gary. I am a breast surgical oncologist, so a breast cancer surgeon, and I'm the medical director of a cancer program in Sellersville, Pennsylvania called Grandview Health. We're recently partnered with Penn Cancer Network, so I think that's new since the last time we spoke. So Grandview and Penn are united in our mission to bring better cancer care to the Upper Bucks County area and beyond. We cover Montgomery County, and for the folks who are local, that means something. But the service area includes over 400,000 families, 400,000 people.
That's a big job.
It is. And there's a lot of cancer in the area. So, you're here in Philadelphia right now, but the entire Philadelphia, greater Philadelphia, Jersey, over to the shore, it's what we call a cancer cluster.
Is it?
Yes, it is.
Okay.
Meaning the incidence in Pennsylvania, for example, of thyroid cancer is 11 times higher. And where I practice, 1 in 4 family members has a first degree, mother, father, sister, brother, family member with a potentially hereditary cancer.
Really?
Breast, ovarian, uterine, melanoma, pancreatic, prostate.
That is so high.
Colon cancer, stomach, gastric cancer. And so, one of the things I think it's important to talk about is knowing your risk and talking about family history. So something we could definitely talk about is, it's secrets and the power of sharing your story. What makes a great talk great. So I gave a talk today. We're here at Living Beyond Breast Cancer at the annual conference that they do for early and locally advanced breast cancers. And I gave a talk on sexuality and intimacy in breast cancer. And what makes it real and what makes it powerful is the sharing of the stories.
Okay.
We can present a full 45 minutes worth of facts and slides and figures, but what people really need to hear is, what my neighbor is saying. And when someone comes into the office, how do you have that conversation with your doctor that says, what, things are good and life is great, but things could be better. I could be happier. I'm having trouble with intimacy. I'm having pain down there. I'm having vaginal dryness. And so the sharing of stories, I think, is something that's really important, and it cannot be understated to your listeners, because we're very sort of closed mouth about our diagnosis. It's a thing, it happened, we want to put it aside.
Exactly.
But it's something that we really need to explore and plant it in the ground among all of us who, plant it in the garden of our lives. Let's say it that way. Plant that seed so that something beautiful can grow for lots of different people in your churches, in your communities, in your homes, in your families. And I think it's really important.
Absolutely. And I think you touched on so many great points, like family history and knowing your risks, and then these topics that for some reason we kind of shy away from. We don't like to talk about it, or we're embarrassed for some unknown reason. So how can we empower our community to say, this is happening to me, and immediately someone's going to be like, oh my gosh, me too.
Sure.
And we talk a lot about quality of life and how does this intimacy play out in that quality of life. And we've heard terrible stories of just relationships falling apart not because of the breast cancer, but because of the aftermath of the breast cancer diagnosis. How do we empower the women to feel confident in their bodies, in their skin, in their new breast forms, or however they're going about it. I was talking to another gentleman, and he was like, you were going through chemo and you were so sensitive I could barely hug you.
Yeah.
Now how am I supposed to make love to you because I don't want to hurt you?
Right.
And so how can we find these new ways of caressing each other and new ways of just appreciating each other in intimate ways?
Yeah, it's very true. I think that the relationship that we have with our bodies before cancer is a somewhat fragmented and a secret one also, because we don't necessarily spend time exploring what we like, whether it's from a self-pleasure standpoint, or even just in terms of giving ourselves dedicated time to do the things that make our lives rich. How about we start there?
Yes.
You know, we go through these obligatory lives of I have to this, I have to work, I have the kids, I have to this, I can take the parents, I got to go to the gym. You know, we fill our schedules with everything that's supposed to bring enrichment, and how much of it actually does. You know, and what portion of your day is actually spent on you? And now I'm talking to myself here, but what portion of your day is spent doing something that makes you feel rich?
Yes.
You know, and that puts you back in tune with yourself.
Right.
And so carving out that time, you know, before breast cancer is nearly impossible. And then breast cancer makes everything stop. And it all comes to a screeching halt. And now your life spins in a different direction around doctor's appointments, around treatment, around therapy, around all these things. And then we say, great, you know, you're done your treatment. Now go love yourself and, you know, live your best life because it was early and we caught it.
Yes.
And it's so
there's no manual. There's
it's
no
unrealistic,
roadmap.
right?
Yeah.
And it's an unrealistic goal. And so the road back to intimacy really starts with self-discovery.
Okay.
You know, and like I said, there's no way to it but through it. And so you've got to spend some time figuring out who you are, what you like, what intimacy looks like for you.
Yes.
You know, and where do you like to be touched? Because how can you help a partner understand in the time when passion is supposed to happen and that things are supposed to be organic? Right?
Exactly.
Things are supposed to be organic at this point, but you're still figuring out, well, it itches here. I don't have sensation here. I don't like it when this hurts, you know? And so figuring out where the sore spots, where the tender spots, but also where the sensitive spots are, where the sensual places are, is something that a woman or a man has to do for themselves.
Right.
You know, and separating and uncoupling all that shame from it too, because there's a lot of shame around our bodies. We don't like to talk about it. We want to look at the scars. We don't want to think about it. But then we want to have an orgasm.
Right.
It just doesn't happen.
Right.
Yeah.
Yeah. I love this idea of kind of self-discovery. Can you talk a little bit more about that? Because I feel like even after a diagnosis, after your surgery, when you are getting comfortable with your new body, I know for myself, I gained a lot of weight when I was going through chemotherapy.
Right.
So I'm going through I had a double lumpectomy. I don't know if that's the correct term.
Sure.
A lumpectomy on both sides.
Yep.
There was reconstruction with the tissue that I already had.
Yes.
Then I was on chemotherapy with a lot of steroids and drugs. Now I'm on hormonal therapies that push me into like medical menopause. And I'm like, you know, on the outside I'm fantastic. On the inside I'm like 85 years old.
Yes.
And I need to, you know, learn to love this new body that I don't want to get osteoporosis, so I'm fighting that.
Sure.
Being in menopause, your body is producing fat like it's your job.
Like it's going out of style, right? Like you are storing
Right.
food for the winter, right?
Yes.
Winter is coming and your body knows it, and it's like, no, winter's here. And there's
Exactly.
no number of Live Strong programs and you know, Zumba classes you can go to that seems to kind of slow it. So I think a couple things, you know, one, I think physicians and healthcare providers and health systems have to set patients up for a better, more realistic expectation, so that you can understand that after surgery, here are things that you could experience, and here's how it might affect not just your physical being, but also your sexual being.
Yes.
Your self-esteem, your intimacy. How are these scars going to feel? How do they heal? Where might you expect pain and for how long? Same thing through radiation. You know, radiation is not just, great, we're going to zap those residual cells, you know, and it's not that. It's, well, after radiation, you may have some skin sensitivity. You may have some burning. You may have some zingers and some numbness and tingling and all these sorts of weird things, so that you could begin to understand, one, that it's normal and natural. Because that just sheds a whole layer of shame and fear and all these sorts of questions that you have. So you can say, oh, this is normal. Well, how long should I expect this? What are things that I can do? How can I be empowered? Is there great arnica cream that I could use? Is there something else, some, frankincense and other essential oils that I can rub that will help some of those side effects? And the answer is yes. I think letting patients know, even through chemotherapy, that, intimacy can be possible, but there are maybe times when it might feel more comfortable to do so, and times when it's natural to not want to do so. So that you've uncoupled the person who's undergoing treatment from the shame and the stigma with the partner too, because the partner is very much left out of the equation. You can sit there and support somebody while they're getting an infusion. You can deal with them when they're nauseous or they have diarrhea afterwards.
Right.
But understanding, where the coupledom is and the vulnerability of that, and where are the times when it might be okay to just, let me just rub. Let me rub your shoulders. And let's connect through touch. Let me rub your feet. Or if you're feeling good, why don't you rub his or her shoulders? And say, you know what, I still value you as a partner. I'm so glad I get to lay beside you.
Yes.
And have somebody to put their arms around me, even though I don't feel like having sex right now. you know, and so redefining the goals of intimacy is a way that keeps you in that vulnerable sort of safe space. And so I would say to patients who are undergoing therapy, you know, the orgasms are not the goal, not the chief goal of intimacy, and that pleasure is a right. Pleasure it's radical. It is something that we should be demanding of ourselves and our lives. And you know, we're here not to just have optional feel-good moments as we go through the perfunctory, movements of our lives, even through our cancer journey and everything else. Because if cancer teaches you nothing else, it teaches you all the ways that you need to put yourself first. And pleasure should be pretty close to the top of the list, and unfortunately, it's usually at the bottom.
Right, because you're living every day just trying to survive, trying to get through the treatment, and like just checking the box. And then all of a sudden, once you're done with your final active treatment, you just expect everything to pop back into normal.
Yeah, and nobody tells you that normal is totally different, you know, and that it's okay. And so I think that setting reasonable expectations, but also giving ourselves a bit of grace. And saying, you know what, during this phase of treatment, here are things that you can do to make yourself feel better. You know, here's a great bath balm. You know, maybe there's a CBD bath balm, for example. Those are wonderful for some of my friends who have ovarian cancer and even with breast cancer, but who have chronic pain. You know, just sit in a tub and light a candle and feel like you again, feel sexy. And that's the goal. You know, the goal is redefining pleasure. So that whatever brings you joy, whatever brings that spark, whatever makes you feel like you is now the radical thing that you do to reclaim your pleasure. And so there's, you know, exercise is a key component of that for many of us, because when our bodies are not moving, we feel achy, we feel stiff, we feel stagnant, we feel tired, we don't feel like our best selves. And so I talk to my patients all the time that the goal of exercise is not for weight loss. Weight loss is a secondary goal that is a necessary one, because we know that fat cells convert, you know, foods that we eat and alcohol that we drink into estrogen, and estrogen makes things grow. It's a stimulus for cancer. It's, you know, but the goal of exercise is to feel better in your body, is to connect with your body, is to get the blood flowing and get the endorphins going, and it's to take a bit of time so that when it's time to be intimate, we're not saying, oh, my back, wait, I haven't moved my neck in this way in so long, now I can't even feel good in my own skin in order to connect enough with a partner.
Right.
Because that's often what happens. We want to connect, and that connection, we want it to be instant. And it's not, because we haven't done the things to get ourselves ready for that connection. And it isn't an instantaneous one anymore. It has to be a very deliberate one.
Yes.
You know, and so to that point, even setting realistic expectations with our partners. And so I talk a lot about, one, touch, but two, maybe the goal, you know, is maybe we only have a date night every 3 months because we got kids and we're taking care of elderly parents and we've got busy schedules and people are traveling or we're undergoing therapy, but we keep our date night, we keep our time together, and we set a goal that, you know, maybe our goal is just we're going to touch. We're going to rub and we're going to feel good, and nobody's going to, and if someone hurts, we're going to have a safe way to say, you know, that doesn't feel as great, but this does when you do this. And we redirect gently and lovingly so that nobody feels left out, shut out. And the expectation is not to achieve, let's say, arousal, or not to achieve an orgasm. It's just to feel good and not feel pain, not feel guilt, not feel shame. And then the next date night looks like maybe we'll just kiss.
Right.
And we'll just see if we even can get aroused. Or we can kiss without feeling guilt, without feeling shame, without feeling pain, without covering something up. And if we can do that for 10 minutes, boy, that's a success. Like, that's a win. 10 minutes is a long time.
Absolutely.
You know, go sit in the car and make them like, you know, like teenagers again. And feel good about that. And having those sorts of slow incremental gains, I think, are things that build our sexual confidence, you know, that make us feel better about our bodies and our intimacy. Because generally from there, if things are feeling pretty okay, you may progress to more.
Right.
But the expectation to progress to more is not there. And that's where the anxiety lies. It's when we expect that I should be pleasing my partner should be pleasing me, and then there's all these barriers and places we haven't gone.
Right. It spirals out of control pretty quickly.
Exactly.
Yes.
Yeah.
Yeah, William and I frequent, actually, the restaurant we went to, Chemo Restaurant.
Yes,
in
I love it.
Boston. So that became our date night locale. And this was one of the places where, when I first got diagnosed, I was so nervous that, you know, going out on dates was a big part of our relationship. And how am I going to go now to this restaurant in public, losing all of my hair, going through surgery, walking around with drains for 4 weeks? Like, how do we deal with all of this? Yes. And we literally brought in the restaurant crew. I'm like, you're part of the family now. Like, you're going to know every week what we're going through. Yep. You're going to see me bald. I remember coming in, I got the little short pixie cut before I lost my hair. They're like, oh, I love your haircut. And I'm like, well, let me tell you why this is like this. Yes. And so, you know, they were That's where we went the night before my surgery.
Yeah.
It was a celebratory dinner to say,
I love that.
Cheers to everyone who's helping us get through this.
And you know what the key is to what you just said, the linchpin to all of it, it's being vulnerable. Mm-hmm. It's being able to be vulnerable enough because vulnerable means intimacy. It means honesty. It means candor. It means license to feel what you feel and express those things. It means that this is a safe space, and I'm creating this. I'm giving myself a space to do this. And to say to a group of strangers at a restaurant, listen, I'm dealing with breast cancer. Can you guys help me out?
Right.
And you know what the natural human response is? What can we do? If they had instruments, I'm sure they would have played them. They probably sang opera and played good music. They cooked the best meal you've probably ever eaten the night before your surgery.
Absolutely.
Because they wanted to make sure that you knew you were loved.
Right.
And you gave them that. That's a gift. Mm-hmm. And you think, oh, I'm the person, I'm the patient. No, you gave them a gift.
An opportunity to serve and help.
And to use the thing that they do every day that they don't think really matters as they go through their perfunctory lives, serving food and holding trays and trying to keep it all together while they're worried about what happens when their kids get off and they're worried about all their lives. You gave them a chance to care about something and to do what they do in a really intentional way to make somebody feel good and to reconnect with what they do in that way. Because they maybe don't think about their lives that way, just like as a surgeon. I go through my days and I recognize the significance of what I do sometimes, but it's a gift that patients give to me too. Because I get to use the thing that I do to help people feel better and live better lives and get rid of cancer. And it's not just me doing a service and doing, a technical service for a patient all day long, but you give me a gift. And how great for me to be in a vulnerable space and say, you know what, thank you for the gift of trusting me with your life and with your body at a time that's probably the most significant of your life. Right. Well, you've given me a gift, and it's a chance to do what I do for good.
Yes.
And I'm grateful for that, So that vulnerability is such a key to intimacy. Mm-hmm. Number one key.
I love how you just described all of that too, because I think sometimes wearing the patient hat, we assume that these oncologists, this is the job. It's a very rewarding job, but day in and day out, you're working with breast cancer. Mm-hmm. But just as you mentioned, this is one of the biggest days of our lives, and for us, it's the first time.
Yes.
So being able to have that vulnerability and empathy for knowing what your patients are going through is amazing. So thank you very much for sharing that.
I try to keep that in mind, whether it's the first day or whether it's the first patient of the day or the 25th patient of the day or the 35th patient of the day. I may have said the same thing in 10 different rooms, but for you, it's all brand new. And I don't get to shortchange it. I don't get to shortcut it. I don't get to leave early and have my hand on the door. I have to make sure that just like I did for the very first patient, the very last patient gets that time and gets those questions answered, because it's a trust relationship and you're trusting me with it. And that's something, it's a gift. I don't take it lightly. So
that's wonderful.
Yeah.
What an honor. So at what point, if you don't mind me asking, do you get to interact with a patient? I know every hospital and institution kind of manages that oncological team differently, whether they're seeing their oncologist or the radiologist or their surgeon first. Can you tell me a little bit about your practice and at what point you get involved?
Sure. So in my practice, patients come to see me from the minute that they know that they have an abnormal mammogram and they need a biopsy. They will either come to see me, my nurse practitioner, one of the other surgeons in my practice, and we're the people who help to coordinate their care through the biopsy. Because after the biopsy, depending upon the outcome, maybe you don't need a surgeon per se, but maybe you need some additional guidance and information regarding how long you should be screened for this thing. Maybe you need 6-month follow-up pictures. Well, what doctor's ordering that? Who's going to go over it with you? And so we become kind of the coordinators of care, and I love that model because it sets you up for understanding the tone of the person who may be operating on you.
Yes.
Versus seeing an oncologist, a medical oncologist first. So I'm a surgical oncologist, or seeing a radiation oncologist or even a gynecologist. I think the relationship with the gynecologist is a huge one. And so from that perspective, seeing a gynecologist first because of that ongoing trust relationship. This is a doctor you have known. It's someone who's done your exams. It's somebody who may have found that lump. And so I think that that's a good starting point. But starting with the surgeon gives you a chance to see what a surgeon will do and say before they operate.
Yes.
And it sets the tone for that surgical relationship. And so I will see patients, I will give them that diagnosis, and I let them know what to expect from the minute that they come to see me. We go over the imaging. Here's a mammogram, here's your ultrasound, here's what I'm thinking, here's what these things could be, and if this, then this is our plan. If it's that, then this is our plan, and if it's this, then we'll talk about that. And so we feel sort of, I like for patients to leave feeling partnered with and like they know what to expect next. Someone has walked them through what a biopsy is and what to expect. So they get to the biopsy and they come back and they say, you know what, it wasn't the most comfortable thing, but at least I knew what to expect. You told me how it was going to be, and it was just like that.
Yes.
and they get their diagnosis, and they come back with their family member and their questions. And we talk about those things, and we prepare them for surgery. Here's what to expect during surgery. Here's what to expect after surgery. Here's what to expect if you're the family member in the waiting room. Here's how you might feel, and here's some questions you might have, and here's the answers I won't have, but here's the answers I will.
Yes.
And then surgery happens, and it's a day like everybody said, okay, this is kind of like what we thought.
Right.
And
So
it
you
makes
prepared them. You set those expectations.
makes them feel at ease. Here's what to expect after surgery. If you're staying in the hospital overnight, if you have drains, if you're going home, if there's a nurse coming to your house, here's what she's going to ask you, and setting up those expectations there. So I think I love that part of it,
Yes.
almost as much as the surgery part, because it helps to just round out what I do, and it makes it, my role is not just the technical one, but it really is as much as possible to help lead that team and guide. I'm an usher. I guide patients through this process, and so I will then see my patients every 6 months for the first 5 years.
Wow.
And I'm clearly not operating on them every 6 months, so guess what we talk about?
Okay.
Quality of life. We talk about how are you doing after radiation? How are we doing with fatigue, and what are you doing to combat your fatigue? We talk about how are we doing during chemo and why you don't lose weight during chemo like everybody thought. You thought you were going to lose weight, and this is not the chemo where you lose weight. This is a chemo where you gain weight.
Yes, they didn't tell me that at the beginning.
Right, nobody told you that. But you know what?
Yeah.
I tell patients that, be careful what you eat. Because if all you're, and it's not even that all you're eating is, let's say, milkshakes. If a milkshake makes you feel like you again, then have a milkshake. But what are some foods and some ways that we can detox from some of the toxic side effects of chemo?
Exactly.
We can have our chemotherapy, but what do we do? What are we putting in our Vitamix and our juicers and our blenders? How are we dealing with our neuropathy? And are there things that we can do? Is there a tea that we can make? Are there foods that we can eat? The antioxidants that we eat are the Pac-Mans that chomp away at cellular damage. And you get them more from your food than from a vitamin and from a pill.
Right.
So what are those foods? How often should we eat them? So we talk about these things.
That's wonderful.
As a surgeon. I think it's a moral imperative for me, because I do a patient no service to remove a tumor and not address all the rest of the patient and the things that impact their survival and their quality of life.
Wonderful.
Yeah,
So
mind and
that
body
holistic,
it's connected.
Yeah, the whole person.
Indelibly connected,
Yeah.
and being an osteopathic physician, it's part of how I train. It's built in. It's not an afterthought, like, the surgery is separate from the medicine, from the psychology, from the, all of it's connected. And if your mind and if your spirit are not right, then healing in your body doesn't really take place. Even though cancer's gone, are you healed? Are you whole? Are you healthy? No. If I don't talk to you about smoking, if we don't talk about the things that'll kill you faster than breast cancer, like stress, right? Right, then I'm not doing you any service by having removed your tumor. I've just removed a tumor, but we haven't removed the thing that's keeping you from living a productive life and having a healthy, whole life. And so the focus is on wholeness and on wellness, even if you have metastatic disease. Can you be well? Can you be whole? Can you be healthy with metastatic disease? The answer is yeah. And to the best that you can, to the best that any of us can. And what does that look like for patients? And so I think that relationship for me is really, it's important. And so I think I answered your question, like,
Yes.
what does my practice look like, and how often do I see patients? But that's the why of it, and I think I wish more doctors would tap into that, because they would find they have more rewarding careers too, and a lot less burnout.
Yes, absolutely. It's a hard job, that's for sure. And to be able to find the joy in what you're doing is really inspiring. So I know our listeners you're going to get a million phone calls. I think everyone's going to want you to be like your surgeon.
Oh, that's awesome. No,
Yeah.
I'm so grateful to have the chance to talk about these things.
And during that consultation that you have with the patient, how do you talk about all of the various surgical options that are available?
So we talk, I like to speak to patients in really simple terms, and then we can sort of elevate the conversation as they're able to understand, because most times you're just trying to wrap your head around your diagnosis. Is it cancer or not? And then someone says all these words like ductal and lobular and, papillary and whatever else, and you're like, okay. And then somebody throws in a grade, and you're like, what's a grade? And they throw in these receptors, and what's a hormone receptor? And so I have a really simple way of explaining to patients. I'll draw diagrams, and we'll talk about what the normal cells look like. So I'll give you an example.
Okay.
A paper towel roll. A breast duct is a tube. It's an empty hollow tube that carries the milk, and it's lined with a layer of cells like bubble wrap. Right? So now you're thinking kid science project, I got a tube and I got bubble wrap. And then, those cells become atypical. Instead of being nice, cute little round bubble wrap, now they're triangles and other weird shapes that don't really make sense. And all of a sudden they fill up the whole roll, and then the roll breaks open. That's invasive. That's why, because it broke out of the place where it started versus in situ being in the place where it started. can of crescent rolls, Pillsbury crescent rolls. My patients love this one. You know, when you pop the can and the dough pops out, it's invasive.
Right.
And so now they're like, okay, I get that. And the husband's like, all right, I get that. And,
we're all hungry.
Everybody,
those.
well, I ruined food for everybody, let me tell you. But then we begin to talk about, the grade, how fast is it growing and what does that mean? And the stage, how do we stage breast cancer? And then, so from there, because I got to walk you through your pathology sheet, because if you don't understand that when you leave, then I get an F for the day. Mm-hmm. Dr. Gary does not get a passing grade if the patient leaves and doesn't understand what they have.
Right.
So we go through that, and then I say there are two main ways that, as a surgeon, that I treat breast cancer. It's either removing the part of the breast that's affected, the lump, and then a rim of normal tissue around it, or removing the whole breast. And we talk about which one you need and why, what the survival benefit is of both. And, if I'm doing a lumpectomy, the survival from a lumpectomy is the same as a mastectomy, as long as I get the margin and we do radiation or x-rays to the breast tissue I'm leaving behind. And you get it. It makes sense. Like, oh, okay, yep, you're taking the lump, you're leaving breast tissue behind. Now you have to treat that breast tissue. Boom.
Right.
And then we talk about what the goals are. We have to bring in genetic testing and whether or not there's a mutation in a gene that maybe means we have a higher risk of this happening again. Because if you knew it was a 60% chance it would happen again in your lifetime, you might make a different surgical decision.
Exactly.
So I kind of let the patient guide the surgical options by finding out what their wishes are, but by partnering and saying, these are what I do. Mm-hmm. And here's one way we can do it. Here's another way we can do it. Take account your family history, taking into account your anxiety, your fear, taking into account your genetics and your hereditary risks.
Yes.
And then we meet and we talk about those things. The other thing that I do that's really important, and I wish that more surgeons did, it's to take into account the cosmetic and the plastic surgery considerations for each patient. So great, maybe you are ample and you have, a very small tumor,
Right.
but are you able to exercise? Are you wearing 2 bras when you go to the gym and you go to run, your 5K and you're taping your breasts because they're too big and they're pendulous and you're uncomfortable? Has anyone talked about a lift or a reduction? Sure. Just because you're 75 years old, does that mean that you don't meet criteria now for symmetry procedures because I have to take a larger lump out of this side? Why should your bra be uneven? Mm-hmm. Why should you have to do that for the rest of your life when you could match and insurance could potentially cover it and it could all be done at the same time? Mm-hmm. Did anybody talk to a patient about that? And so I try to make sure that, whether it's a young patient or an elderly or geriatric patient, I've got some octogenarians who drive and wear lipstick and, they are living their best lives. Mm-hmm. And some of them have had lifts and reductions because it makes them feel whole. And so I think that, as we talk about surgery, not just the surgery that I do, but what are all the surgical options for you and making sure that you understand and feel partnered with.
I love that.
Mm-hmm.
Yes. And so taking the person's wishes into consideration,
yep.
painting the whole picture so they have all of the options available to them so that way they can make their best choice.
What's going to make you feel as good and as whole as possible because you didn't ask for this.
Right.
You didn't cause this. But can we use it as an opportunity to maybe turn some things around in your life, mm-hmm. including how you look?
Absolutely.
Yeah.
I remember when I was first presented with surgical options, it was almost like choose your own adventure,
mm-hmm.
right? Like start at point A, do you want to go open this door or do you want to open that door?
Right.
And then at the same time, you're waiting for all of your genetic testing to come back.
Yes.
So that also plays a role in the type of surgery I was going to be eligible for.
Right.
I did neoadjuvant chemotherapy.
Yes.
So the goal was to shrink the tumor
Absolutely.
early on to see if I was eligible at that point for breast conserving
right.
Surgery,
yes.
which was exciting. So,
mm-hmm.
We're trying all of these options that, again, it was kind of like this big smorgasbord of
yes.
could
do this, could do that,
exactly.
might do this, maybe do that.
And it was constantly being tweaked, every single time. I think that was something that I was not expecting as
mm-hmm.
a type A person. I
yes.
wanted a plan, I wanted to follow my plan. And I hear this a lot from our community members of, how do you let go of that plan? It's not a perfect science, and I was okay on the plan, and then the plan changed, and now I'm a mess. And so I think I had on the other side of that too, right? I tell people, you had to let it go and trust that relationship you have with your team mm-hmm. because they have your best interest, and because they're changing your plan time and time again, it's because things are progressing in a positive way, and there's more available to you.
Sure. I think the days of the sort of prescriptive medicine for cancer are gone mm-hmm. because cancer medicine, oncology is so personalized, even down to the surgeries we do. If I do a nipple sparing, will I hide the scar? Will I put the, I could put it on this side of your areola. I could put it under the arm, under the breast. There's so many options. And if you want to keep your breast, then my goal as a surgeon is to do everything I can to make that possible, make you feel as whole as possible walking out of that surgery. Mm-hmm. And so if that means we need to give some medicine up front to make that possible, couple, then that's what we can do for you. And the plan, you know, I had a couple who came to see me recently, and it's been a very difficult cancer journey for them, and the plan has continually changed and shifted and morphed, and her husband was so frustrated, and he said, listen, we thought it was this, you said it was this, and now it's this, and now it's that. And, you know, I wish that patients knew that in the era of personalized medicine, the days of this is the surgery you get, this is the radiation you get, this is the chemo or the not chemo or the pill or whatever else you get, the days of that are nearly over, because the information constantly comes in and the changes are ongoing, and the plan can shift based upon the margins. Do I need to go back and take a little bit more? You know, are you happy with how you look? Do I need to do a little fat grafting and maybe fill in that defect? Or do we need to change the plan because the chemotherapy maybe didn't work and now we need to talk about a different surgery? Did our genetic testing results make our risk that much higher? Or your own level of personal anxiety around this diagnosis and ongoing surveillance? You know, do we need to maybe consider some different options for you?
These are all great questions.
And so helping patients to understand that it is very much not a linear process, but that it's a very personal one, you know, individualized, I guess is a better word than personal, because of course it's personal, but it is also very individualized.
Yeah.
And as the information changes about your individual tumor and your biology and your genetics, the plan may change as well. And that, you know, being patient with that, but also that's why you got to trust your care team. You said something so important, because if you don't trust your care team, you're going to be like, wait, what's happening here? You know, and there's an art and there's a science of medicine. But one thing that doctors can do, we can do better, is refer patients to the guidelines that we use.
Okay.
So I'll give you an example. You know, the National Comprehensive Cancer Network, NCCN.org, has the algorithms for how every cancer doctor treats a different cancer. If the patient has a tumor this size, if the receptors are this, if they're this, then that, and what things should you order, you know, PET scans, etc. When is a PET scan not indicated? Because everybody wants to know that question, and we could spend, you know, $1 million and a million years scanning you from head to toe for an early stage breast cancer and work up things that you may have never, you know, known that you've had. But because we see them, now we're obligated to do something about them. And so PET scans are not indicated in certain circumstances. But helping patients to know and to understand their journey, NCCN has a really great website for patients and also for physicians. It's a place where we go and we can look at the algorithm and see where our patient fits and also where our patient maybe doesn't fit. Because in the guidelines, there are all these little asterisks and footnotes, and, you know, personalized medicine happens in the margins.
Okay.
It's not in the mainstream.
Right.
And so if you're in the margins, somebody should be looking for you there and should be trying to figure out what you need and partner with you there. But that there is a roadmap, but it is a little bit circuitous. It's like Candyland. It's not. It's like chutes and ladders. It's some other sort of roadmap that, you know, can take you for a loop sometimes. But being patient and trusting your provider and making sure that that provider is transparent with you, because as long as I'm telling you what I would do if I were sitting in that seat, if you were my sister, if you were my mother, if you were my aunt, what questions would I ask? I'd ask these questions. I've got these answers for you. What treatment options would I be considering? I can certainly tell you that as a person who's watched their family members, you know, struggle with cancer, and some have lived with it and some have not, you know, and I can give the best advice and the highest advice I would give if it were me.
Right.
And so when you find that doctor and you have that trust relationship, then you go on this journey together.
Yes.
You're not going on it by yourself. I promise you, you're not. Yeah.
One of the best pieces of advice that I received was, if your oncologist is not your best friend, you need a new oncologist.
Oh, I love that.
And I'm like, absolutely, because these are people you're talking to all the time. You're sharing your most intimate desires and questions and concerns, and they are there helping you beat cancer.
Yep.
And so I was like, absolutely, best friend all the way.
I love it. Circling back, you got to ask about sex.
Yes.
And they should be asking you, and if they're not, then you got to train your doctor a little bit, because nobody teaches us how to have these uncomfortable conversations either. We learn how to give a lot of uncomfortable news. You know, we learn how to deal with mortality and how to help patients hopefully be okay with that while we're trying to fight for survival. You know, there's prolonging death, and then there's, you know, providing dignity and preserving life. And so understanding that balance is a nuanced thing that doctors learn years and years into their career, but having uncomfortable conversations about things like sex and intimacy, you know, and it's not always just the male doctor and the female patient. I've got some male patients with breast cancer, and guess what Dr. Gary's going to have to do?
Absolutely.
I'm going to have some really uncomfortable conversations with my male patients and try to make them feel at ease and make sure that I'm not remiss by not asking, you know, how are things for you from this standpoint, because it just wouldn't be fair. just because I'm a woman doesn't mean that I can't talk to a man about these things. Asking the husbands and the partners, and the single people. I can't tell you after this talk how many people who are single that came up to me and gave me a hug and said thank you. Nobody ever talks about what it's like to be single with breast cancer.
Yes.
And how hard it is to even find someone to touch you and to figure out what your goals are in intimacy if you don't have an intimate partner. How do you even initiate that all over again? And what are the stigmas associated with self-satisfaction and self-pleasure?
Yes.
And the lady said, you freed me today. And like, that's my why. That's why I do what I do.
Yes.
I love surgery, and surgery is a tool that I use to do this, but there's so much more that we contain multitudes.
Yeah.
There's so much more that we can offer a patient when we take the time and really get to know, all the aspects of cancer care and speak to those things. And so that's what I love about my job.
Yes. Oh, I could talk to you for hours.
I know. We're like old friends chatting here too.
This is amazing. I mean, I think just anyone who's listening to this right now is going to feel so empowered, inspired, knowing that they're going to feel good about their body. And now that they have the tools to actually have these conversations with their spouses, with their doctors, I think you did just open up the door for so many people. So thank you.
It's as easy as just saying, hey, can we talk about this? Or, not waiting until that very last second when the hand's on the doorknob and you say, oh, by the way, or could you send in the nurse because I want to, I have a question. And it's to say to you, hey, listen, doc, I've been doing some reading, and or I listened to a webcast, a podcast, and I read something, I saw an article, or what, I've just been meaning to bring this up, and I don't know how. It's really uncomfortable for me, and I don't mean to make you uncomfortable either, but I'm having some dryness down there. Things are painful. Should I expect this? Is is this what I should expect? And if this is what I should expect, then are there anybody that could help me to find ways to get over this? Are there any things that And so not always challenging someone's direct knowledge, but are there resources you have? Is there anybody else I can talk to? And there's a saying, the closed mouth doesn't get fed, right?
Yes.
And so, we gotta advocate for ourselves in that regard, because pleasure is not an option. Your pleasure is a radical right. It's a necessity, right? It's not just a right and a privilege. It's a necessity, and it is a very radical one that we should own it, embrace it, and look for it and expect it again. How wonderful would it be if you could expect to have good intimacy again after breast cancer? Like, there's something to look forward to there.
Absolutely.
And it's definitely a journey, and I'm not saying it's an easy one by any stretch of the imagination, but it takes us opening our mouths and being vulnerable, partnering, all the things. Like, it pulls all of the life lessons, it pulls it all together into one box and wraps it up like, here's your biggest life lesson right here. And if you can manage those things, to your point about the stress and anxiety and the need to control everything, it starts with knowing that you can't control everything. But these are the areas where I can feel empowered. And it's about physicians and nurses and caregivers helping people to maximize the opportunities to feel empowered. You can't control this, but here's what you can do. This happened, and this is what this is the surgery you need, and here's the pain that you might experience. But here's what you can do.
Yes.
You might not feel like being intimate right now with your partner, but here's what your partner can do. Here's something that's going to feel really, really good. Here's a massager just for your feet and for your neck and for your back. What if you massage the small of her back? What if, touching the bottoms of feet, maybe it doesn't feel good with neuropathy, but maybe there's a warm soak or something you can do. There's a soothing caress. And so making sure that we feel empowered with our options helps to alleviate some of that need to control everything, because you just can't. And that is the blessing and the curse of breast cancer, is learning that you cannot control everything.
Right. Sometimes, just out of your control, and there's
It is.
nothing you can do about it.
Yeah.
So I've been meditating a lot and telling myself even, like, how busy we can get in our own lives.
Yeah.
And I was like, Laura, you're bringing this on yourself. Like, take a deep breath. It's not that busy. You're making it busy in your mind because you have to do this, you have to do this. You're going and going and going. Like, why am I doing this to myself? And it was a mindset.
Sure.
And then I immediately was like, I'm in control. I'm not busy. Like, I mean, we're all busy.
Yeah,
but,
we
like,
are. Sure.
It's how I'm confronting the day-to-day.
Sure.
And it was like a light bulb.
Well, and you can get a little deeper than that, and as physicians, we do it all the time. We're super busy because it takes away from the fact that our lives might not be as robust as we like, and that our relationships are struggling, and that, I'm having a problem connecting with my kid, and that, I'm not eating the right foods. And so I bury under busy, because busy feels better than sitting with myself and my thoughts, even as that's a universal thing, as a physician, as a patient, as a doctor, as a, as a sister, as an aunt, as a partner. Right. And so there's some layers to peel back there, but the best thing that we can do is to be loving with yourself. And to lovingly do that and say, you know what, I'm doing this. This is my coping mechanism right now because I would like to see myself here. And it's not saying that I'm not doing, you got to get rid of the negative self-talk, but to say the person that I want to be, I see myself being more balanced. I see myself being, having time for pleasure and redefining pleasure. I see myself making more time in my day for these things. And I'm not there right now. I'm starting to see why I'm not there right now. And it's really unpack that, but just be really loving with yourself and say, you know what, that's where I want to be.
Yeah,
and if that's where I want to be, then that's where I'm going to get.
Absolutely.
Yeah, but you got to be loving with yourself. Say sweet things. Sometimes I'll compliment my patients because no one else does, and because they deflect the good compliments. Their spouse says, oh, you look really nice today. They're like, yeah, uh-huh. And they'll say something negative about themselves, and I say, you know what, Dr. Gary said you got really nice legs. You do. You got great legs. And every time you walk by that mirror on your way out your door and you look at yourself, and you should say to yourself, I got great legs. Or I've got a great smile. And I said, if you can't say it for yourself, then you look at yourself in the mirror and say, Dr. Gary said I have a nice smile.
I love that.
Until you believe it yourself. And until you're able to say something good about yourself. We got to do that. Yeah. And it starts with us.
We can do it.
We can. We could so do this.
Absolutely. And that's what I love about the podcast, too, because it's almost like going to confession. Like, we're just talking and we're speaking to millions of listeners who tune in every single week for positivity, hope, advice, empowerment, encourage,ment and love. And we're giving that.
It's super vulnerable. It
absolutely.
Is for me as a speaker, and for you as a patient, and as an interviewer, and as a caregiver, and as an advocate, and as a fighter for all these listeners. I applaud you for what you're doing, because it's not an easy road. It is not, and it takes you on the road probably more than you'd like to be, and so you got to remember to be loving and gentle with yourself,
absolutely.
And to carve out time with your spouse, and make sure that you are doing all the things that we're talking about for others.
Got to take care of ourselves.
We got to do them for ourselves too. Yeah, so that's my work in progress. I'm telling my patients to exercise at home, and I say if you can exercise during the commercials. Just during the commercials. You give me an hour TV a night. Guess what? You've gotten 25 minutes of exercise without leaving your couch.
That is a great idea.
It's super hard, though, because you know how hard it is to do arm circles? And I have tried this while watching American Idol. Do arm circles, do stretches, do leg lifts. I mean, I've done it myself.
Gosh.
I'm out of breath like the first 3 minutes, and this is so sad. I'm like, really, Gary? Really? And this is what you're telling patients to do. But guess what? If they can do it, I can do it.
Absolutely.
And I haven't made it through a single hour of TV yet by exercising for the full 3-minute commercial break, but I will.
Yeah.
Eventually I will. That's right. And you know what? I got accountability buddies.
Yes.
Every exam room I go, and I'm like, all right, what's our goal? I'm going to see you in 6 months. What are we working on? You're working on this? Guess what? I'm working on that.
Yes.
And they always ask me when they come back to see me,
they?
Doc, how you doing with stress? You said your stress levels or your knees were aching and you needed to change your shoes. And you know what I did? I got acupuncture. And now I'm able to talk to my patients about acupuncture because I did it myself, and my knees feel better, and I can wear my 3-inch heels in clinic.
That amazing.
But being vulnerable, is just such a great lesson. It is, and being honest.
You started the conversation off with, like, sharing your story, because it's that vulnerability. You're putting yourself out there, but you're not the only one going through it.
Yep, and I can't expect you to share yours if I can't share a piece of me, because this is a journey that we go on together. Every single patient, every cancer patient I deal with, we're on that journey together.
Dr. Gary, thank you so much for all of these words of wisdom.
Thank you for having me.
Okay, we'll have to just do this again. There'll be a follow-up, because I
feel
like we're just scratching the surface on positivity, self-image, sexual healing, surgery options, so some ideas for potential future topics.
Okay.
I would love to kind of take a deeper dive. I've spoken to some women who have gone through various infections and then unfortunately now are no longer available to have certain types of reconstruction.
We can talk about that,
so we can definitely talk more of some of those heavier topics. Myself, for example, after going through a lumpectomy and radiation, the breasts do change.
Yes.
And so what options do we have to say, okay, they started off good, but now they're changing size.
Right.
And I'm not sure I'm so comfortable with this anymore.
Right.
So what options do we have as those who've been, through lumpectomies?
Yep.
And also, one of the burning questions that we get all the time also is the topic, especially among young women, about fertility.
Okay.
So you mentioned earlier that those who've been diagnosed with breast cancer tend to see you first in your clinic, and you kind of shepherd them through the entire piece. So at what point does that conversation of fertility come up?
Oh, yeah.
So
we'll talk about that.
Okay. To come, but
great.
So stay tuned, but this was phenomenal. And I want you to continue to enjoy the Living Beyond Breast Cancer Conference this night, and
I'm so glad we got to connect.
You too.
I'm so glad to see you. And keep doing what you're doing. Let me know how I can support you. For anyone who's listening, if you have questions, you can follow me on Instagram. I'm Dr. Monique Gary on Instagram. I'm not that active yet, but I have a feeling after this conference I'm going to need to be.
Absolutely.
I do have a website also, drmoniquegary.com, where you can submit questions. I'm on the Grandview Health website, www.gbhgrandviewhealthgbh.org. And you certainly can reach out to me there for consultations and to make appointments. And I'm just happy to connect with all of you in whatever ways that I can, because it's such a process and we cannot do it alone. So I thank you for having me.
Stunning. I'm going to cry. I love you.
I love you too. I know.
We're hugging for those who can't see it. We're hugging it out. Group hug. Group hug, everyone.
Group hug.
If this podcast was helpful, be sure to subscribe, share with your friends, and leave a review so we know that you liked it. There are so many ways to join our community. Be sure to subscribe to our weekly newsletter at survivingbreastcancer.org. Follow us on Instagram, survivingbreastcancer.org, all one word, and on YouTube at bit.ly/YouTube SBC, and on Twitter, SBC_ORG. If you have a topic idea or would like to be a guest on our show, please contact me at laura@survivingbreastcancer.org. We love hearing from you. Please remember that the content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions. Views and opinions expressed in our podcast and website are our own and do not represent that of our workplaces. While we make every effort to ensure that the information we are sharing is accurate, we welcome any comments, suggestions, or corrections. In no way does listening, reading, emailing, or interacting on social media with our content establish a doctor-patient relationship. Thanks. Until next time. Talk to you then.